Good morning and welcome back to the channel. I hope that everybody is doing well today. I'm back at work. So for today, I thought I would take you along again for a day in the urgent care. It seems like a lot of people really like these kind of videos, show you what to expect if you're going to work in the urgent care. I've been here for almost a year now, so I'm pretty comfortable. I'd say I'm actually very comfortable now with my position and my role here. And so it's fun to show you guys around and keep you involved and let you know what's going on. So today I'm working 11 to 7 p. I'm actually the second person coming on right now. Somebody got here at 9 and they'll stay till 4. This is our Sunday. We're only open from 9 to 6. I think I said that right. Yeah, I'm 11 to 6 today. He was 9 to 4. So I just got here and I'm looking at the chart right now. He has already seen in these 2 hours 13 patients, and we have currently 8 in the waiting room. So it is obviously been a very busy morning, and right now I just pulled 2 patients over to my chart and I'm going to go see them. The other ones haven't even been roomed yet. We don't have enough space. So the 2 patients that I have pulled over currently are both pediatric patients, both with like flu-like symptoms is what it looks like. Both have stable vitals, but fever, nausea, vomiting, and headache. Both of them unrelated, and this has been a lot of what we've been seeing. We have seen a lot of influenza A recently, and locally our mask mandate was rescinded in the schools, and so the flu is definitely making a comeback. In fact, I'm very afraid for my family that we're going to get the flu. As you know, I have a 7 and a 4-year-old, and they are both in school. And I feel like the rate this is going, it's just a matter of time before it hits our house. Knock on wood, I should really. But yeah, so I'm going to go see these patients right now. I'm going to go do a quick evaluation. I love pediatric patients. I actually love children. Part of me wanted to work in pediatrics, so this comes very naturally to me. Of course, I'm a mother and I have that nurturing aspect, but some of the providers that I work with really prefer not seeing pediatric patients. I'm always happy to take on all of the peds. I personally find them pretty straightforward. I mean, generally speaking, kids that have less comorbidities and are on less medications, and I just feel naturally inclined to want to help and nurture children. So I'm going to go check out these babies right now. I'm sure we'll do a flu swab. Like I said, we have that here. We have COVID and flu, but I haven't seen COVID in a while. So we're definitely going to be testing them for the flu. Will give them each, if they're still really nauseous and vomiting, I'll probably still give them some Zofran and do like the PO challenge here in the office where you give them a dose of the Zofran and then see that they can tolerate liquids by mouth before going home. Obviously, too, if they do come back positive for the flu and they're within that window of time, I'll do the Tamiflu for them as well. It's available in suspension form and pill, so these both are quite young. So if Tamiflu becomes the appropriate choice for them, then I'm sure I'll do the suspension formulation. But I'm going to go in there, take a look, evaluate my kiddos. I'm sure we'll flu test them. I'll see if there's anything else that we're going to do. I doubt it, but you never know when you go in there. I've been surprised. I look at a chief complaint, and then I go and see the patient, and it comes to find out there's a lot more going on. So we'll see. I'll check back in with you guys as much as I possibly can. Like I said, of course, we're very busy, but I'll do my best, and I'll take you along. Knock, knock. Alright, so as you can see, I did go and see both of my patients, and now I am sitting down to chart. So for patients with these upper respiratory infection complaints, my approach is generally the same. What medical history do they have? What hurts them? When did their symptoms start? Have they had a fever? And what have they tried at home? Also, I generally ask if they've had any known sick contacts. I look in their ears, their throat, I palpate the sinuses, and I check for lymphadenopathy. I listen to the heart and the lungs, and then depending on the complaint, I will also do an exam of the abdomen. And then, of course, I make sure to specifically ask in the adult population about chest pain or any difficulty in breathing. Okay, so here you can see a little bit of how the charting looks using DocuTap. So right now I am actually charting my exam that I just completed. So I either use a pediatric or an adult template, and what it does is it automatically inputs all normal findings, and then I have to go through and obviously manually input any abnormals that I found on my exam. And then I can also unclick or uncheck any boxes of data that either isn't relevant to the patient or that I didn't personally examine. And so as you can see here, I'm putting in my diagnoses for the patient. And like I said, usually they want you to have 2 diagnoses per patient. So those are your ICD-10 codes. I looked those up and they kind of give you some options. I always choose uncomplicated, unless of course it's complicated, in which case I put that. Fluids, rest, follow up with your PCP, and then return to clinic if symptoms change. I always input. And then for this specific patient, they were a pediatric patient, so I included alternating appropriate dosages of Tylenol and Motrin. And then you can see here also I give them some discharge instructions. So what I included here was headaches for pediatric patients. Make sure to print that out with their discharge paperwork so they have something to go home and reference. I obviously try and print out any instructions that are pertinent to whatever chief complaint that they came in with. And then after this, I do my dispo. So this particular patient went home. And then last but not least is coding. I always code at the low or minimal, depending on if they're fee for service. All right, so I went and saw those 2 patients, and it's actually been a couple hours, so I've seen some other patients as well. Those 2 patients, the first 2 kiddos that I saw, did in fact test positive for flu A, and then we've had a few other flu A positive kids after that. I think I've seen probably 5 children with the flu today. And then they're telling me like their classrooms are out, a lot of them are sick, so it's definitely going around. So I did Tamiflu for all of them. They all were within the window of time left, it was all within 48 hours of symptom onset. If you've done Tamiflu, then you know it's weight-based. Obviously with children, it's weight-based. So, and I use not Emra because it's not antibiotic. I use Epocrates for dosing everything that's not antibiotics. And just for reference, I definitely always recommend that when you're doing any kind of prescribing of medications that you reference to make sure that you're doing the correct dosing, especially with children. Obviously, you have to be very cautious as they are, majority of the medications that you give children is going to be weight-based. So number one, it's always really important that you're getting an accurate weight on these children. Confirm that what you have is the correct weight, so you make sure that you're giving them the correct dose. So, but for example, for Tamiflu, for 1 to 12-year-olds less than 15 kilograms, they get 30 milligrams by mouth twice a day for 5 days. And there is a suspension available. I think it's 6 milligrams per ml. Hopefully I'm remembering that correctly. But then you would do like your cross multiplication and you would figure out based on their kilograms in weight, or their weight in kilograms. For patients that are 1 to 12 years old, 15 to 23 kilograms, and it's 45 milligrams BID. So the dose obviously continues to climb the more that they weigh. So 1 to 12 years old, 23.1 kilograms up to 40 kilograms. Now they get 60 milligrams BID for 5 days. And then children over 40 kilograms, they get that adult dose of 75 milligrams BID for 5 days. Again, it's always good to remember that children should never have a dose larger than an adult dose, and if that's the case, then you just give them the adult dose. It should never be larger. Also with these patients, a lot of them are very congested, and with kids, of course, we don't give that much medication, right? Children, we're much more conservative with our management. One thing that I do like to recommend for the kiddos that are very congested is children's Zyrtec. And of course it's over the counter, but a lot of parents just don't know to use what medications are safe and effective for children. Children's Zyrtec, I really like that one. I'll help dry up some of that drainage, especially if they're having a lot of postnasal drip and just really congested in the nose. So it's good. It's a good reference to have for dosing for that. So, and they can have it as young as 6 months old. 6 to 11 months old, they can have 2.5 mLs. 12 months old up until 5 years old, they can have 2.5 mLs twice a day. So you can tell them to do it morning and night. A max dose of 5 mLs or 5 milligrams a day. And then as old as 6 years old and up, obviously they can have the full dose of 10 milligrams in a 24-hour period of the children's Zyrtec. So they can do, 5 milligrams in the morning and 5 in the evening. And that's just really to help alleviate all of that congestion. Of course, too, I always educate on alternating Tylenol Motrin. I discuss with them the correct dosing, the correct timing. Motrin you can do every 6 to 8 hours, Tylenol every 4 to 6. Lots of fluids, lots of rest. I always encourage something like a Pedialyte. But yeah, so we've seen a lot of flu. That has been we're definitely having a local outbreak right now. I have a gentleman here right now that I'm about to go see, though, who is here for right foot pain. And on here it says that he fell 1 week ago. So I'm going to go ahead and assess him and see what's going on. And I'm sure we'll get an x-ray and we'll see what we're going to do. And I'll let you know. So when I went in to assess the patient, he told me that he had a mechanical trip and fall 1 week ago, and he rolled his right ankle inward. Patient reports swelling and tenderness to palpation at the lateral malleolus and the dorsal aspect of the midfoot. He is ambulating with a slight limp and mild pain. Sensation and neurovascular status remain intact distal to the injury. So based on the Ottawa ankle and foot rules, I did order an x-ray of the right ankle and the right foot. While reviewing an x-ray, I make habit to scan each bone individually, tracing the cortex of each bone, looking for any abnormalities. Also, you can see here that changing the contrast, lighting, or using bone enhancement can help when reading and interpreting an x-ray as well. So after reviewing the x-ray, I did not see any fractures or dislocations. Everything appeared to be intact, and though we do get an official radiologist read, those generally take within about 24 hours of imaging. I diagnosed the patient with an ankle sprain. I provided him with an air cast and then instructions on what to expect as far as the recovery process. I make a habit to educate my patients with a musculoskeletal injury to wear their ankle cast or ace bandage or whichever is determined to be the most appropriate to wear, and I tell them to continue wearing it until they return to baseline strength or baseline mobility. Also, I always provide an orthopedic referral. If they determine that they aren't recovering as expected, then they can contact them for a follow-up. Kind of steadied out now. It's not as busy as it was initially in the morning, and so I'm completely caught up on my charting, which is wonderful because we're actually about to close. Hi, editing Brittany here. I just wanted to hop on here and say, for full disclosure, if it looks like I'm bouncing between two different offices, it's because I am. So the one that you'll see me at where I'm charting and sitting at the computer and working at the desktop, that is the office that I generally do sit at. That's the office that I chart at and do all of my work at. When I'm talking to the camera, I actually go into a separate office just nearby, just because it's easy for me to close the door and kind of separate from like the patients and all of the commotion of the office. So I do go from office to office, and it's just for like privacy purposes. From your end, this day probably seemed very fast, but yet actually on our end, it was very busy. That was one of the busiest mornings I've seen in a long time. And like I said, a lot of it I think has to do with so many sick kiddos with the flu. That really was the predominant thing, the predominant chief complaint today. It always seems like there's a theme of the day. And today it was kids with the flu, which makes me extra apprehensive that my children are going to get this, seeing as it seems to be in a lot of different schools, local schools. So hopefully that doesn't affect us, but we did get our flu shot this year, although I did hear that this specific flu vaccine, heard that it has not been the most effective influenza vaccine, so knock on wood. But yeah, like I said, I finished my charting, so I get to go home and just have the rest of my Sunday with my family. As always, I wish you guys nothing but the best. Hopefully you enjoyed this. Hopefully you learned a little something. It was a pretty straightforward day, nothing too exciting to show you guys, but still, hopefully you enjoyed following along for the day. And until next time, I wish you guys nothing but the best. Don't forget to like the video, subscribe to the channel, and I will see you very soon.